Hello, everybody. A very good afternoon to one and all. I welcome you all to another series of Algos Academy webinars. And today's session is titled Decoding Peripheral Nerve Entrapments of the Upper Limb. Upper limb neuropathies are very common and they are very much misdiagnosed also. We many of the time think it's only cervical radiculopathy or any tendinopathy or any myofascial pain syndrome. A structured clinical approach combined with imaging precision can dramatically improve outcomes. Today, we are privileged to have with us Dr. Petra Abulhosn as our faculty for today. And about Dr. Petra, I'd like to say that Dr. Petra completed medical school at Lebanese American University and started residency in emergency medicine for a year before deciding to move to the United States to pursue physical medicine and rehabilitation residency, which she completed at New York Medical College and just recently completed a primary care sports medicine fellowship in 2025 at Montefiore Einstein, New York. And it's a privilege to have Dr. Petra with us. So, Dr. Petra, before we begin, just want to start with asking a small question to you. What drew you specifically towards the interesting topic of peripheral nerve pathology within the scope of musculoskeletal medicine?
Hi, Dr. Khan. Thank you so much for having me. It's nice to see you again. Thank you for the kind introduction as well. Actually, this is one of my favorite topics to begin with, having a PM&R background, and then the addition of primary care sports medicine, in which you become very trained in ultrasound. I've always liked all the pathologies in the upper extremity. And when we're talking about decoding any nerve pathology there, it's for me, it's like a puzzle, it's a game because you have to figure out where exactly is the nerve entrapped. So like you said, we use all the tools in our what we have, such as physical exam, EMG, ultrasound, to figure out where exactly is the nerve entrapped. And in the end, it's pretty interesting to figure it out and go through the process. And then my favorite part is the ultrasound. Obviously, I'm sports medicine fellowship, so I like the intervention and the procedure to help figure it out, whether it's a diagnostic or interventional for treatment as well.
That's great to hear. And yes, Dr. Petra, so the stage is yours. You can start with your presentation. Kindly start with sharing your screen.
Thought it was sharing. Give me a second. Can you see it well?
Yes. Yes, screen is visible. Kindly make it full screen.
Yep. Okay. Do you see my cursor as well?
Yes, yes, we can see. You can start off, Dr. Petra.
Okay. If do you want to do questions along the way or in the end, or how do you usually do your webinars?
We can have the questions in the end. You can complete your
Okay.
presentation in one go.
Okay. All right. So getting started, I have no disclosures. This is the outline of the presentation. I'm gonna do a quick spiel introduction about the brachial plexus nerve injuries, EMG, and ultrasound. All right, my topic today is gonna be focused on entrapment, presentation, diagnosis, treatment, and ultrasound for the following nerves: radial, ulnar, medial, and then we have a bonus slide on the suprascapular nerve as well. So what exactly is an entrapment neuropathy? So it occurs when a peripheral nerve is chronically pressed by surrounding structures like ligaments, bones, or muscles. Obviously, it can be compressed by other things such as scar tissue, cysts, lipomas, any laceration or fractures. But for the purpose of this presentation, we're going to be talking about something that we have already naturally in your body that causes this compression. So like already mentioned, you use your tools at your disposal for any diagnosis and treatment. Physical exam is very important, but then we also can use EMGs and ultrasound to figure out where exactly the nerve is compressed. I mean, obviously, you can use other advanced imaging like MRI as well. Okay, so entrapment neuropathies can be acute, subacute, or chronic. We have typical and atypical locations, and then these typical and atypical locations could also be common or uncommon. So before we start the presentation, you have to know what the different types of nerve injuries are. The first one, which is the mildest form, is neuropraxia. basically what we call a stun nerve or a funny bone, when you hit your elbow and you have pain. So this is basically when you have demyelination, problem with the myelin sheath, and you get conduction slowing or a conduction block. The next one is axonectomesis, when you do have axon damage and the myelin, but the intact surrounding of the connective tissue is still intact. Here, we have Wallerian degeneration. There is a high likely of recovery, and we know that the nerve recovers 1 millimeter a day or 1 inch a month. When you have neurotomesis, this is complete discontinuity of the axon and connective tissue. This is a surgical intervention, and recovery of a full nerve is unlikely. So why do we use EMG or nerve conduction studies? It can help diagnose and assess severity of our condition. It can help us determine the location of insult. However, we know that to get proper results, the nerve conduction studies, we would need to wait about 10 to 14 days for that. And to get EMG, we would need to wait 3 to 4 weeks after the insult. Ultrasound, however, it's been increased its use exponentially over the recent years. We've been having better resolution of ultrasound. The advantage of that is you can actually follow the nerve along its whole course. You can perform any dynamic maneuvers at any points of potential compromise. It's easily accessible and cheap. You can use it for diagnostic and interventional treatment. And what you usually see, would see nerve swelling versus atrophy. You can see compression along the nerve, so you would see a nick on the nerve, and then you can also notice any loss of internal normal fascicular pattern. I know this is everyone's worst nightmare. At one point, we had to all study it for exams or in med school. I'm just going to give a quick spiel about this, just to get to our peripheral nerves. All right, so we have our nerve roots, cervical nerve roots, C5, C6, C7, C8, C1. These usually travel between the anterior and middle scalene muscles, and as soon as it goes out of these muscles, we get to the trunks, superior, middle, inferior. We have the anterior 3 divisions and 3 posterior divisions. And we have the medial, lateral, and posterior cords. And then finally,
Hello,
the terminal branches. Can you
Dr.
hear me?
Petra?
Yeah.
Yes, there is a bit of a lag break in your connection. Can you talk now?
Okay. Yeah, can you hear me?
Yeah, now it's slightly better. Now it's better. Now it's better. Yes. Your video is frozen.
Okay. What slide can you see?
This roots, trunks, divisions, and chords. Yeah, now
Should
it's
I go
better.
backward?
Now it is better. You can it's you can continue from the brachial plexus slide.
Okay.
The brachial plexus slide.
So
Yeah.
here? Okay. I didn't say anything about here
Yeah,
much.
from there. Yes.
Okay. So basically moving on was just breaking the brachial plexus down into roots. We know we have the cervical spine roots C5, C6, C7, C8, T1, and these travel between the anterior and middle scalene muscles, which then become the trunks, superior, middle, and inferior. Then we have the divisions. We have 3 anterior and 3 posterior, and then we have the cords, the lateral, posterior, and medial cords. Finally, we get to our terminal branches, musculocutaneous, axillary, radial, ulnar, and median nerves. Are we okay on the slides? Mhm.
Yes, okay. Okay.
Okay. Okay, so for the sake of our presentation today, I'm going to be talking about these 3 nerves, like I already mentioned. And then we have a bonus slide of the suprascapular nerve. So radial nerve, it's a derivative of the posterior cord and gets innervations from all 5 of the cervical spinal roots. What does it innervate? So motor, we know it's an elbow extensor, triceps, and anconeus. It's a weak elbow flexor for brachioradialis. It's a supinator as well, and then it's mainly a wrist extensor and finger extensor. And for sensory, it provides innervation for the posterior and inferior lateral portion of the arm, posterior forearm, and lateral dorsum digits 1 to 3 and half of digit 4. It's very important when you're trying to figure out where the peripheral nerve is damaged is to know the course of the nerve itself. So after coming off the posterior cord in the brachial plexus, it goes under the axilla. It wraps around laterally to the spinal groove right here, and then it pierces the lateral intermuscular septum to become to the dorsal compartment of the forearm, and then makes its way down. Okay. And if you know an idea of this, and then anywhere along this route, wherever you have an injury, you can kind of figure out on the presentation where the location is by knowing that anything above that injury would be spared and anything below would be damaged. I'm going to use this slide for the sake because it's just easily presented. All right, so we're finally getting started to the gist of our presentation, and this is our first insult. So if we have radial nerve damage at the axilla, what do we get? So this is a well-known pathology. We call it Saturday night palsy or crutch palsy. What happens when someone uses it the wrong way and they put too much pressure on their axilla, they can compress the radial nerve in the armpit. Or when they say Saturday night palsy, someone had too much to drink alcohol, and they sleep in the wrong way, putting pressure, such as this photo right here, at the armpit as well. In this case, we have weakness of all radial nerve innervated muscles, including the triceps and anconeus, and that's how you differentiate it with other parts of the nerve injuries, and then sensory loss of all the radial innervations as well. So basically, you would present with a typical wrist drop, finger drop, burning, tingling pain, and weakness with elbow extension as well. And then the numbness sensations and tingling sensations would be along all radial nerve innervated sensations. But what happens when you have it here in the spiral groove? This is what we call honeymooner's palsy. As you see, you have pressure from the wife's head on the spiral groove, which causes compression at the spiral groove of the radial nerve. But here, why am I also calling it Saturday night palsy? And this is a confusion that presents all over the internet. And the difference between the presentation before and now, I mean, they can both be called Saturday night palsy. It just really depends how you sleep on your arm when you have a lot of alcohol to drink. So they're both right. It just depends on the presentation, right? So here, the main thing is we have intact elbow extension, and that's sparing of the triceps and the anconeus. And then the rest is the same. We have wrist, finger drop pain. And then another note importantly is these nerves are spared. So we basically have numbness along the yellow and red parts. If you want, I can go back to show you why is that. You would right here, you can see that the nerve gives off the innervations for the posterior cutaneous nerve of the arm and the lower lateral cutaneous of the arm before compression of the spiral groove. All right, so in this case, I mean, we can use the nerve conduction studies or EMG to confirm diagnosis and assess severity. As I said, you would have to wait proper at least a month to get proper diagnosis and to actually have changes shown on the EMG. So the treatment in this case, we remove offending agent, and that's basically for every nerve pathology. Educate if it was honeymooner's palsy or Saturday night palsy, educate them on the causes of drinking too much, sleeping the wrong way, using the crutch, educate on how to use it the right way, and not to sleep in that position. Occupational physical therapy, we brace the wrist and the fingers so prevent contractures. Also, if you can see here, we usually put the brace in, this is called the functional hand to get proper extension of the fingers. So they can still use their finger flexors to actually grab something and to have a good hand grip. Also, pain and neuropathic meds work in this case for the pain, and ultrasound guided treatment and hydrodissection have been shown to help speed up the process and help with the pain as well. Also, PRP in some cases do help. Okay. Moving on. Insult right here. What do we get? We have here sparing of brachyradialis, ECRL, and ECRB, and the supinator. And what is this pathology? Here we get into two terms. We have the pin syndrome versus the radial tunnel syndrome. In general, what is a radial tunnel? So it's basically a zone. It's a 5 centimeter muscular aponeurotic space between the elbow and forearm where the radial nerve passes. And then the arcade of Frosch is a specific fibrous semicircular arch forming the proximal entrance to the supinator muscle within that tunnel. And that is within the radial tunnel, and it's actually the most common site of radial nerve compression. So when we differentiate these two terms, basically when we use the term radial tunnel syndrome, we talk about pain. So that's why it's very confused with lateral epicondylitis. It has no motor deficits and it's mainly pain in that area. When we talk about pin syndrome, it involves the compression of the nerve deep into and the radial tunnel, and most commonly in the arcade of Frosch. It could be compressed by other structures as well. And here, like I said, we have sparing of the brachioradialis, ECRL, ECRB, supinator. So we would have mild wrist drop and it would deviate radially. The ECU is still damaged, and more importantly is the no sensory loss. The pin is only a motor nerve. Why does this happen? Usually it's caused by repetitive pronosupination within the elbow at 0 to 45 degrees of flexion. So any handyman that uses a screwdriver or any tools that they use a lot of pronosupination, I actually had patients that are deaf, so they use their hands a lot for signing, and they also had it on both hands because of their supinator. And again, when I say supinator syndrome, it's basically another term for radial tunnel syndrome. Treatment for this is basically the same as the ones before: therapy, pain meds, bracing if motor involvement, and we can also use ultrasound-guided hydrodissection or injection. If severe cases at the arcade of Frosch and no improvement, we can also refer for surgery. Here, if you can see, the insult is just on the superficial radial nerve, and this is a known phenomena. We call that, has so many names actually, chiralgia peristatica. It's also called Wartenberg syndrome, and it's known as handcuff palsy. You have compression of the superficial radial sensory nerve. We have no motor weakness, and basically patient presents with pain, sensory, numbness and tingling in this area right here. Same management, we remove the offending agent, pain management, and then you can also hydrodissect the nerve. People are using many different formulations for hydrodissection. Could be steroids with saline, with lidocaine, D5 alone, or with steroid, a mixture. And many more people are trying to use PRP for nerve injuries as well. Just put this slide in the end to keep in mind that even though we're talking about peripheral nerve entrapments, we need to have the differential of having basically, in this case, posterior cord plexopathy or a C7, basically a radiculopathy. This is a cheat sheet, but if you do have posterior cord, the axillary nerve is involved. So you would also have weakness in the deltoid or latissimus dorsi. And then you should always keep in mind also your cervical radiculopathies. Just keep in mind that there is no snap. So in the nerve conduction studies, the snaps would always be normal when it's a radiculopathy. I just put in a few slides of ultrasound. This is from the MSK room. They really have good images if you want to take a look at it. It's an online book that you can purchase. So here, the ultrasound is in the anterior elbow. You can see the capitellum and the trochlea. The radial nerve lies between the brachialis and brachioradialis muscle. Going a bit further, this is when it crosses here to go out to the lateral intermuscular septum before it goes off into the forearm. And you can see here the radial nerve between the humerus, and you can see the lateral intermuscular septum right here. This is the triceps and the biceps muscle. And finally, making its way into the arcade of Frosch. If you see it right here, these are the two heads of the supinator muscle. And these two dots here are for the radial nerve. And I put in this slide for some pathology. This is in short axis of the nerve. On the left side here, you can tell the difference between the two different sides, and the nerve here is a bit thickened and enlarged. And then if you also see in longitudinal axis, you would see the same thing here and here. Before moving on to the ulnar nerve, Dr. Han, is the slides showing well? Am I lagging or?
Yes, yes. Slides are showing well. You're not lagging. You can continue.
Oh, okay, cool. So ulnar nerve is a derivative of the medial cord, has innervations from C8, T1. Motor-wise, innervates the flexor carpi ornalis, the third and fourth FDPs, adductor pollicis, deep head of the FPB, interossei, third and fourth lumbar curls, abductor digiti minimi, opponens digiti minimi, and flexor digiti minimi. Sensory-wise, it gives innervation to the dorsal cutaneous branch, palmar cutaneous branch, and superficial sensory division. And this is the way it courses towards the upper extremity. It starts off from the brachial plexus, the medial cord goes medially under the axilla, and then it stays medially throughout the course of the upper extremity. Starting from here, so an insult in this area is usually from the arcade of Struthers. So this is the 68 centimeter. It's usually proximal to the medial epicondyle. It's a thick facial band that usually arises from the medial triceps all the way to the medial intermuscular septum. You can see here the ulnar nerve is passing through it. In this case, because we're very high up and we're above the elbows, so all ulnar innervated muscles are involved, including the flexicarpi ulnaris, and all ulnar sensation is affected. So we would have numbness and tingling in this areas because all three branches are affected. Okay, and when we have ulnar pathology or ulnar neuropathy, these are common signs you would see in exams or have to know of.
Put it here. I will do it.
Okay. So first one here, you would usually you can look for first dorsal interossei atrophy. This is called Warneberg sign, not syndrome, the one that we saw before. And this is because we have weakness of the adductor digiti minimi. And usually you can ask the patient to put their hands in their pocket and you would see the pinky hanging off. And this is Foreman's sign. You ask the patient to hold a paper between their thumb and their finger like this. However, when we start pulling away, they can't use their adductor pollicis. They start using their FPL, as you can see here, which is median nerve innervated, because this is weak. It's because it's an ulnar derivative. These are both causes of ulnar neuropathy. However, on the right side, this is from proximal ulnar neuropathy, and this is more towards an ulnar nerve injury at the wrist. And why does this happen? When the ulnar controls the lumbar curls of 3 and 4, and the lumbar curls usually flex at the MCP and extend at the PIP and DIP. So when you have injury to that, you're going to get extension at the MCP and flexion of the PIP and DIP. So this is a typical ulnar clawing, the one that we see. However, if you have an injury of the ulnar at the elbow, you don't see much of this clawing. Why? Because you also have weakness of the flexor digitorum profundus. So that's why you don't see much of the clawing, but they're basically both presentations of ulnar neuropathy. And this is what we would see at the arcade of Struthers, this type of clawing. Okay, next we have an injury also close to the elbow, but slightly below it. And this is more common. It's called any injury, any compression at the cubital tunnel. So the boundaries of the cubital tunnel, we have the arcuate ligament of Osborne, which is basically called the retinaculum of the cubital tunnel, which stretches between the olecranon and medial epicondyle. The floor is composed of the MCL and the elbow joint capsule. The medial wall is the medial epicondyle, and the lateral is the olecranon process. So the tunnel is basically the entrance of the arcuate ligament, and it ends at the two heads of the FCU. But when I talk about cubital tunnel syndrome, and this is the second most common type in general of peripheral nerve entrapment, usually it's between the two heads of the FCU, but it could be compressed in other structures in the cubital tunnel. Intermittent symptoms that are worse in flexion. Here you do have FDP involvement, but the FCU is spared. As you can see here, depending where it's structured, but if it's in between the two heads of the FCU is spared because the innervation towards the FCU is provided before it goes in between the two muscles. And then here we also, similarly to the arcuate of Struthers, we have a possibly weak ulnar hand. So same presentation. And then the treatment, conservatively, we have activity modification, nighttime splinting to keep the elbow in neutral position, pain management, and bracing. As well, we can use ultrasound-guided hydrodissection. I've done actually D5 prolotherapy hydrodissection on both of my elbows for cubital tunnel syndrome. It worked well for about 2 months, but I haven't done any nighttime splinting, which I should. And then if it's chronic, severe weakness and no pain with the above, so we would refer for surgical for decompression. Okay, next, an insult in this area. It's famous Guyon's canal. It's the canal is made between the two bones of the carpal pisiform and the hook of the hamate. It begins at the proximal extent of the transverse carpal ligament, and the roof of it is the volar carpal ligament. And I have more pictures to show you exactly what I'm talking about. And what runs through it is the ulnar nerve, ulnar artery, and vein as well. Here, causes, it's also called cyclist palsy or handlebar palsy, is putting any pressure towards the Guyon's canal in that area. So intrinsic trauma, long distance cycling, using the palm as a hammer, chronic pressure from screwdrivers or pliers. Intrinsically, it's a common area to get a ganglion cyst, and then obviously any nerve, if you have a trauma laceration or a tumor, can compress that area. In this case, however, the dorsal branch and the palmar branch, the innervations go higher before it enters the Guyon's canal. So these would be spared, and you would get numbness and tingling solely in this area. The superficial branch is only affected. Here, since the injury is more at the wrist, you would get more of this type of clawing versus this type of clawing. Treatment is conservative, activity modification, padded. If it's from cycling, you ask them to wear padded bicycle gloves. Pain management and ultrasound-guided hydrodissection also works well. Surgical failure for this is rare. Again, another cheat sheet to always keep in mind other differentials when you're looking at ulnar neuropathy. You need to think about medial cord plexopathy. In this case, median nerve would also be involved. So you would see changes in the APB or the FPL, and then also keep in mind radiculopathy as well. Some ultrasound images, starting off in the arm. You would see the ulnar. I like this positioning or putting the hand behind the head for ulnar scanning. Here you can see the ulnar nerve. This is the medial head of the triceps, and this is the brachial artery. Following it down, you could either, for Guyon's canal, you can either be in this position or in the position that the previous slide showed, which I would prefer. It's very difficult to get an image of the Guyon's canal between the medial epicondyle and olecranon. And when I was talking about the Osborne's ligament and the retinaculum, basically this is what it is. So in the ultrasound, it shows right here. And the ulnar nerve just shows as a hypoechoic structure. It's very difficult to get proper high resolution when you're in this position specifically. What I would suggest is start a little bit higher or lower and then try to find it through. So moving on, going more into the forearm, you would see the ulnar nerve right under the FCU between the two heads, and this is the flexor digitorum superficialis and FDP, and then the ulnar artery. If you go a little bit more distal, these two always run together. So that's one easy way to find the ulnar nerve. So same thing here. This is the ulnar nerve. This is the dorsal cutaneous branch that branches off the ulnar nerve right here, and then you can also see the ulnar artery with it. And lastly, when we're talking about the floor of the transverse flexor retinaculum of the carpal tunnel, it forms the floor of the Guyon's canal, and then the volar carpal ligament is actually a branch of that flexor retinaculum that forms the roof of the Guyon's canal. So you can see the pisiform bone, the ulnar nerve, and the ulnar artery, and this would be considered the Guyon's canal. And you can look here if the patient has any pain that you're thinking of. You can check for any compression of if there is a cyst, if there's any swelling, if there is a nick at any point. Oh, okay, I put this in. So this is basically just showing that you have a ganglion cyst right here, compressing the ulnar nerve right here. This is the ulnar artery. Okay. Moving on to the median nerve. Median nerve is formed from the medial and lateral cord. Motor-wise, it innervates the pronator arteries, FCR, palmaris longus, the flexor digitorum superficialis, FDP, FPL, and pronator quadratus, first and second lumbricals, and then the thenar muscles. Sensory-wise, lateral palmar hand and digits 1 to 3, and half of digit 4. This is the course of the median nerve, and we're starting with an insult to this area or a compression at this area. And this is a common location for a ligament of Struthers. So this ligament arises from, not everyone has it, so there's a supracondylar process, like a small bony protrusion of the humerus. And so the ligament connects the humerus to the medial epicondyle. And it's a rare fibrous band of connective tissue. And in that case, because we're very high up, we have all medial muscle nerves affected. And this is called the hand of benediction when you have a problem with FTS and FTP, so you're unable to flex your first digits. It's similar to the ulnar claw, but they're different depending what you ask them to do and instead of flexing or extending. We all know this is the carpal tunnel or median nerve sensory innervation. Very common, and it's the same type if you have an injury in the higher elbow. In this case, other than ultrasound and nerve, I just put that we can include X-ray to see if we can see that bony protrusion of the supracondylar process of the humerus. Treatment in this case, you can try hydrodissection to decrease compression of the nerve and decrease inflammation, pain management, occupational therapy. But if it doesn't work, this is most probably going to be a surgical referral to shape down that bone area and remove that compression. Okay, next, compression. This is a well-known phenomenon. We call it pronator teres syndrome. So the median nerve runs between the medial and lateral heads of the pronator teres, as shown here. Symptoms, pain and tenderness in the medial forearm that is with pronation, numbness in the median distribution, including the thenar area, and we have minimal motor findings, but you could have weakness of the APB and flexures of the forearm. This is basically the opposite of supinator syndrome. What can cause this? Any hypertrophic pronator teres, tight FDS. Laceratus fibrosis is basically a facial band extending from the biceps tendon to the forearm fascia. So instead of being compressed between the two heads of the pronator teres, also in this area, we do have that fascia laceratus fibrosis that comes off of the biceps tendon, can also be compressed there. But it's in the same area, but it's not as common as. Excuse me?
You can carry on.
Oh, okay, sorry. Okay. Next insult of the median nerve, we have AIN nerve neuropathy, which is a pure motor nerve as well. So opposite to the pin nerve, we have the AIN nerve. In this case, it's pure motor, and basically what you test the patient, known to all board exams, is testing the OK sign. They are unable to do it, and that's because you have weakness in the FPL here, right here, and weakness of the FTPs 2 and 3. Causes of that, you could have, some people have a Ganser muscle, accessory muscle, which is an accessory head of the FPL. Any trauma, it could be a manifestation of neuralgic amyotrophy, which is Parsons-Turner syndrome. Treatment of that would be the same. Any pain management, occupational therapy, trial of ultrasound-guided hydrodissection, and surgical referral if no improvement. Again, no sensory deficits in this because it's a pure motor nerve. Okay, and this basically, I'm sure everyone knows, if you have median nerve compression at the wrist, most commonly, it is the most common overall peripheral nerve entrapment of the upper extremity, and it's the carpal tunnel. What makes the carpal tunnel? It's the carpal bones on the floor and the sides, and then the roof is the flexor retinaculum, which is the transfer carpal ligament. And what runs through the tunnel, we have the four FDS, four tendons of the FTP, the FPL, and the median nerve. Causes and risk factors, repetitive wrist and hand motions are associated. Diabetes, hypothyroidism, rheumatoid arthritis, obesity, pregnancy, and then obviously any compression from a cyst or a neurofibroma. But the vast majority of the cases are idiopathic. Presentations, we do have paresthesia, numbness of the second, third digits, and sometimes thumb, hand, and lateral fourth digit. Usually patients complain of numbness in the whole hand because they can't differentiate. Here we do have nighttime awakenings. That's one thing that you could differentiate from a pathology of the median nerve higher up. And then we have weakness. If it's more severe, we have weakness of the thumb adduction and opposition. And then we all know the provocative tests that we can do on exam. Median nerve innervates the loaf muscles after it enters the carpal tunnel, which are the first two lateral lumbricals, the opponent's pollicis, the abductor pollicis brevis, and the FPB as well. I put in this slide just to show that I think because it's the most one that we have research on, that we can also use ultrasound for measurement in this case. So basically a cross-sectional area of the median nerve at the carpal tunnel, if it's greater than 1.3, you would get specificity of 93 and 91 sensitivity in the diagnosis of carpal tunnel. They just went higher up to give you a high specificity and sensitivity, but a lot of clinicians are using 1 or 1.1 to 1.2 for diagnosing carpal tunnel. You can also use a wrist to forearm ratio of 1.4 or more. That showed 100% sensitivity. A lot use a less, but if the higher you go, you would get higher sensitivity. So like I said, we have a wide variation in reported cutoff value for the cross-sectional area from 9 to 14 millimeter. And then the average is a diagnostic accuracy of 82%. And then just keep in mind, if there's a prevalence of the bifid nerve, it increases the cross-sectional area without having any necessary pathology. Treatment of carpal tunnel, again, is bracing, therapy, activity modification, focus on ergonomics if that's the case. Also, the most studied ultrasound-guided hydrodissection is in carpal tunnel, and they've used many different combinations. A lot of them work, some more than the other, like prolotherapy better than saline, and then there are people who use injection with steroid or without, and then a lot of people are using PRP as well for carpal tunnel. And then surgical referral is definitely an option, and we have conservative versus so endoscopic or ultrasound guided versus still old school open-handed carpal tunnel release. Okay, starting for imaging, if you want to start at the anterior elbow, you would see the median nerve here right between the pronator teres and brachialis. Oh, I think I already put that. Here you would see this is the median nerve and long axis, and you can see thickening of where after it gets compressed versus how the median nerve looks here. And that's the beauty of ultrasound, is that you can track it in short and long and see the difference. This is a cool slide just to show you the median and ulnar nerve, and I think you have a good separation of the flexor retinaculum, and you can see how it encapsulates this to make it the Guillon's canal. And this is the median nerve right here. And the FCR is outside the carpal tunnel. So similar to before, so you have two images in short and in long. They're both pathological, one more than the other, but I just wanted to show that sometimes in ultrasound you can see a nick of the compression, which really helps out the diagnosis. And then you can tell the difference between thickness of the nerve as well. Okay. So one of the few last slides, we have suprascapular nerve palsy. It comes off of the C5, C6 and superior trunk and innervates the supraspinatus and infraspinatus. And then this is also common in overhead athletes. So if we have insult right here or a compression right here, we get compression of both the supraspinatus and infraspinatus when it's higher up. That's usually from the compression of the transverse scapular ligament shown right here. So this is called the suprascapular notch, and it is compression from this ligament that encapsulates it right here. Then you see the nerve courses through and goes to this, goes inside the sphenoglenoid notch before giving its innervation to the infraspinatus. So if you have an insult here, you only have weakness in the infraspinatus, so only weakness in the external rotation of the shoulder. This is very common, and I actually had two cases during my fellowship here in sports medicine. It was a ganglion cyst from the labral tear at the sphenoglenoid notch. Obviously, if you have other diagnosis in mind, you need to rule out an EMG to rule out radiculopathy, plexopathy. What we did is we did aspiration of the cyst, and then we did PRP in the shoulder joint because of the PRP. He had a PRP, a labral tear. And then just to note, you can tell if there is infraspinatus atrophy as well of the athletes, and then obviously you do a physical exam to determine which muscle is affected. So there's just images on how to look for the suprascapular nerve. If you go to the spine of the scapula, put the ultrasound straight down, you would see it lying there, right underneath the supraspinatus. And then at the level of the shoulder joint, you can see here the humeral head at the glenoid, you would see the suprascapular nerve as well, but that's after it comes off the sphenoglenoid notch. And this is the infraspinatus muscle. All right. Okay. I'm open to any questions.
So I think it was a very engrossing presentation, Dr. Petra. Clearly delineated most of the important peripheral nerves which go into entrapments, and a lot of high yield information as well for the participants. So now the floor is open for the questions. If anybody have any questions, kindly either you can put in your questions in within the chat box, or you can unmute yourself and you can directly ask Dr. Petra as well. So Dr. Petra, yeah.
Yeah.
Are there any questions? You can unmute yourself and you can ask Dr. Petra. Yes, you were saying something,
No,
Dr.
I
Petra?
think someone was asking the book. I think I
Yeah,
mentioned the
they
book
have
for the
inquired about the
ultrasound.
book.
I'll write it down for you. How many sessions of prolotherapy is recommended for nerve? I mean, there aren't specific guidelines for nerve entrapment specifically. So I really can't answer to that. Every clinician is different. Some people do several. Some people, if they find a lot of changes and patient is asymptomatic after one session, they would not repeat it. If they're completely asymptomatic, and if some are still in mild pain after doing a first session, they would still repeat it after the second session, 2 to 3. I think Dr. Khan, you do several prolotherapy sessions, correct?
Yeah, so again, it depends on a lot of indications. One thing is how much of a nerve damage has happened, that you'll have to have a look after you get the various investigations done. And especially in case of carpal tunnel syndrome, if it is there, if you're thinking of median nerve entrapment, then usually we do at least 1 to maximum 3 sessions wherein we see the benefit for the patients.
Yes.
So, Dr. Petra, one question from my side to you. Usually, we have seen that a lot of with peripheral nerve entrapments, it's a very tight rope which, as a clinician, we have to walk on. So, what are the red flags that suggest that we should refer for an early surgical opinion?
I mean, I would always, at the same time, refer to surgery if I'm seeing significant motor weakness or atrophy. At that point, I know the nerve would probably need a surgical consultation to see if we can save it in any way as quickly as possible. Um, there's no harm in doing any ultrasound guided hydrodissection in the meantime and still get a surgical consultation just to help speed the process along. But definitely, if I'm seeing significant weakness or atrophy, I would initially always send to surgery as well for their consultation to see if they can, save the nerve quicker than usual.
True. It's very true because very important to know when to intervene, when not to intervene, especially keeping in mind red flags as such. So one more question there is you use the ultrasound quite a bit, right? So how reliable is the
Yeah.
ultrasound compared to an EMG in case of peripheral nerve entrapments?
I mean, it's different, right? The EMG is showing you problems with the muscle itself, and if it's not getting enough nerve innervation and it's weak, so you would get probably more objective results, I would say. But the ultrasound is quicker, it's faster. You don't have to wait a month to see the results. Um, and you use it for a different way, right? Because you're using it, you can do sonopalpation where the pain is exactly where the patient is. You can use it dynamically to see if any movements specifically cause more nicking or compression to the nerve. So it's a very useful tool as an add-on, especially in carpal tunnel. Nowadays, a lot of people don't even send for EMG or nerve conduction studies before they do any ultrasound guided treatment because we can also use ultrasound for diagnosis. But if it's a case where you're not really sure where the nerve injury is, where it is, or you're maybe confused if it's a plexopathy or radiculopathy as well, I mean, EMG, nerve conduction studies is always beneficial.
Agreed. Very true. So, which entrapment neuropathy do you think in the upper limb is actually overdiagnosed?
In general,
Yeah,
overdiagnosed.
because many
I
of
don't
the
know. I wouldn't
time
say I don't.
we see
Yeah.
patients coming in with could be like for example, patients come in with neck pain radiating towards the upper limb or upper limb numbness and all. Many of the time we are very fast to tell that
Oh,
this could be a carpal tunnel syndrome or this could be an
yeah,
entrapment,
yeah.
but we need to keep the other
Agreed.
differential diagnosis in mind, right?
100% agreed. Also, like a lot of referred pain from myofascial pain, people always assume it's carpal tunnel. Yeah, agreed. I mean, carpal tunnel in general is still very common. It could be clinical, even though EMG says there's no
Yeah.
changes. But I mean, you should keep in mind, like you said, definitely myofascial pain syndrome.
And I remember we had also seen a case of carpal tunnel syndrome during your fellowship time over here, the bilateral carpal tunnel
Yeah,
syndrome.
yeah,
That
100%.
was also quite an interesting
We
case,
scanned it and we measured it.
wherein
Yeah,
there was flattening of the nerve also, I think we had seen on the scan.
yeah. There is a
There's
question
another
that says
question you have here.
for cubital tunnel syndrome, apart from hydrodilatation, I think hydrodissection, do we fenestrate the Osborn ligament? So cubital tunnel syndrome, the more common, I have not seen any compression from Osborn ligament. The more common is compression between the two heads of the FCU. And so you would hydrodissect that. But theoretically, if it is a compression from the Osborn ligament, I mean, you can fenestrate or do tenotomies to that area for sure.
True. So you were just, yeah, they are inquiring about the book from where the
Yes, yes,
photos have been
MSK
taken.
Room. It's a
They
website
are
called
finding it very impressive, the
MSK
photos
Room.
on your slide.
Let me write it down. So it's a website where you would have to register and then get that book. It's ultrasound of the musculoskeletal system inside. Let me write it.
So, Dr. Petra, you were talking about ultrasound guided hydrodissections, right? So, what is your protocol for the ultrasound guided hydrodissection? What volume, injectate, and what frequency? Could you just elaborate on it, on your protocol?
To be honest, because I was trained in the US, so you have to use what you have for insurance purposes and what the hospital provides for you. What I've been reading, I do see people have a lot of good results from D5W alone without steroid use as well. And there are studies that show alone is superior to even just steroid alone. Um, what we use is we have available. So we do use 20 milligram of Canalog. We put a little bit of lidocaine, and then in total, we use about 3 to 4 cc's. But as well, there are studies that show 5 to 10 cc's. The higher you go, the higher the volume, could have better results than what you usually use. But we don't usually go above 4 cc's in where I trained. What about you for carpal tunnel
My
specifically?
protocol is I usually prefer, I've been seeing good results with 5% dextrose, and I'm happy with that. Not much of steroid use, even with 5%
Yeah.
dextrose itself, we've been seeing good response in patients.
Yeah.
So, when you talk of hydrodissection, so how early do you start off with the rehabilitation aspect? Is it immediate, or do you wait for some time and then start? What is the protocol there?
It's gonna differ, right? So for carpal tunnel, I mean, I don't really see much um, benefit to therapy or occupational therapy for carpal tunnel. Um, when I talk about cubital tunnel, or let's say supinator syndrome, after hydrodissecting, I would give them a few sessions of therapy. It can start right away. It doesn't. There is no timeline for rehab, in my opinion. It really depends what the patient also wants. Some patients want to try therapy, rehab before doing any intervention, so that kind of goes along that way.
Okay, there's another one more question in the chat box.
Should I look for happen in such cases?
Can
I
cubital
actually,
tunnel, yeah, mimic Hansen's disease?
I actually have no idea what Hansen's disease is. Do you? What is it? Cubital tunnel specifically.
Hansen's disease, basically, they're trying to ask you if it is similar to leprosy. Have you heard of leprosy?
Oh, yeah, of course. Can it mimic it? I mean,
An infection. Are you with that?
no. I
Yeah.
mean, there's definitely you would see much other symptoms when you have leprosy and not just any focused
I think the presentation
all
will be
nerve
starkly
leprosy.
different in Hansen's
Yeah.
disease and cubital tunnel syndrome. The presentation itself will be quite different. Of course, one thing is the altered sensation, which could be a one common linking fact. But apart from that, hypopigmented patches are more common in Hansen's compared to the cubital tunnel syndrome. Right. So
Interesting to look into.
now you have been in sports medicine as well, right? So you have been seeing a lot of athletes as well. So how are the outcomes, especially compared to treatments in the athletes, compared to a general population, when you do the rehabilitation and these procedures? Is there a difference
Yeah,
in
definitely. I mean,
outcomes?
so athletes, that's their career, right? And they have someone with them. They have athletic trainers, they have physical therapists. They're very dedicated, I would say. And most of these, in general, not just nerve injuries, in general, any pathology, knee, shoulder pain, a lot of these can be fixed with rehab, fixing the muscular imbalance, fixing the technique of what's causing it, any biomechanics or disruption in the biomechanics of the musculature. So they're very dedicated and they take it to heart. Whereas most of our patients, I'm fortunate to say a lot of people don't actually believe exercise can help your condition and they rely on medications or injections. And I always tell them, I can help you, but if you don't do the rehab, it can always come back. So I definitely see better, quicker and better improvement in athletes because of their dedication towards the rehab.
Very true. So, one more question is there any role of regenerative treatments like PRPs in case of nerve entrapments?
There is actually. I did read a couple of articles for PRP for carpal and cubital tunnel. Um, Also, probably supinator is common, so any like arcade approach. People are using it. There are not a lot of case reports or case studies, but I mean, I think PRP is the future. I really rely on it for a lot of things as well. It doesn't have to be hydrodissection here of the nerve. It's basically just using PRP 2 to 3 cc's in that area of compression.
Fair enough. Okay, so I don't see any more questions in the chat box. So I'd like to ask you if you have to give three clinical pearls for the young pain physicians for managing upper limb nerve entrapments, what would they be?
So basically, always look physical exam. I mean, I know now included, I rely a lot on ultrasound, but always keep in mind your physical exam. Test the muscles, keep in mind the nerve root and how it goes. Um, and then use other tools at your disposal, like ultrasound nerve conduction studies. And lastly, I mean, don't, I know you can easily figure out a diagnosis sometimes by just hearing the patient speak, but don't also rule out other things which could be more scary, like more plexopathies, cervical radiculopathy. So always keep those in the back of your mind.
Very true. So before we conclude, I just have a small announcement. Just want to do a small announcement, and that is about our upcoming workshop. We have our next workshop slated on April 12th. That is ultrasound of spine from scanning to interventions, cervical, thoracic, lumbar, and sacroiliac. Full day loaded with ultrasound of spine. And today we are announcing it, and the registrations also will be starting from today. Early bird registration will be starting from today, going on till March 10th, followed by regular registrations. So before I conclude, Dr. Petra, thank you so much for a very structured and clinically relevant session. And I'd like to have your thoughts on your experience today.
No, thank you so much for having me. It was a pleasure speaking about it. It's actually one of my favorite topics, so always happy to speak about it. And yeah, I'm always happy to do any more, so let me know. Keep in
Sure.
touch.
Definitely. Thank you very much. And at Algos Academy, our focus has always been on bridging foundational knowledge with real world interventional precision. We look forward to many more such academic collaborations with you, Dr. Petra. Thank you very much.
Perfect.
And thank
Thank you
you
so
all,
much.
our participants, for making time on a busy work day in a late afternoon and joining us. The session is recorded, and soon the recording will be uploaded on our official channel. It will be shared to you as well. Thank you very much, Dr. Petra. The feedback also has been very positive, as you can see.
That- Awesome. All right. Have a nice day, everyone.
Have a nice
Bye
day.
bye.
Thank you.